Welcome back. We are on chapter 13. We're going to be going over vital signs and monitoring devices. We're going to discuss the topics of gathering the vital signs, and monitoring devices. In this section, we're going to talk about gathering the vital signs. Okay, gathering vital signs. It is a major component of assessment that will take a few minutes to complete. The vast majority of patients should have an assessment that includes vital sign measurements. It helps to indicate important condition or trends in patient conditions that require particular treatments in the field or that prompt transports to the hospital. It's taken during the secondary assessment after the primary assessment to find and treat immediate life threats. In this section, we're going to talk about vital signs. What are a vital sign? So, outward signs of what is going on the inside of the body. The pulse, the respirations, the skin, color, temperature, condition, pulse capillary refills in infants and children, pupils, blood pressures. Oxygen saturation is not a vital sign, but often included with the consideration of vital signs. So when you are taking their pulse, their respirations, looking at their skin color, temp and condition, pupils and blood pressure, you should automatically be getting their oxygen saturation. So you'll hear us talk a lot about baseline vital signs, which is the first set of vital signs that are obtained. And then any repeat vital signs are to gain further information by establishing trends. So if it's a stable patient, you can get by with doing those every 10 to 15 minutes. If it's an unstable patient, you should be doing them every 5 minutes. Next, we're going to talk about the pulse. The pulse is a palpable pressure of the heart beating, causing the blood to move through the arteries in waves. It can be felt by placing a fingertip over the artery where it lies close to the body's surface and crosses over the bone. Taking a patient's pulse concerns two factors, the rate and the quality. Here's what this picture is assessing the pulse rate and quality. So you want to count for 30 seconds and multiply that by 2, and that's how you will get the heart rate or the pulse rate. So for the pulse rate, it's the number of beats per minute. A normal rate for an adult at rest is between 60 and 100 beats per minute. If it's considered a tachycardic rate, it is above 100 beats per minute and it's rapid. Or bradycardic, the rate is below 60 beats per minute and it is considered slow. All right, any pulse rates that are above 150 beats per minute or below 120 beats or below 50 beats per minute across several measurements is considered a very serious finding. So during an emergency, if it is not unusual for the pulse rate to be temporarily between 100 and 140 beats per minute. So typically anxiety or stress or even trauma can cause a patient's pulse rate to increase. So think about it. What normal situations might account for a heart rate outside of the normal range? Well, I just talked to you about a couple things just a slide prior. So it could be the trauma, it could be anxious, stress, or so forth, or just being in the situation of having to call 911, your heart rate will increase. So what is pulse quality? So there's two factors that determine pulse quality. It's the rhythm, which reflects regularity. So it's regular when the intervals are between the beats are constant, and it's irregular when the intervals are not constant. Okay? So the other one is force. So the pressure of the pulse wave as it expands artery, and then the pulse should feel strong and thready is when the pulse feels weak and thin. So the common pulse locations include the radial, which is used in patients 1 year and older. It's found in the wrist and found by placing 3 fingers of the thumb side of the patient's wrist just above the crease. Next one is the brachial. It is used in patients 1 year old or younger, and it's on the upper arm pulse. So here you can see that they're palpating a brachial pulse in an infant. I highly recommend always trying to feel a brachial pulse in an infant when you have a healthy infant rather than having an ill infant that you have to now try to figure out where it might be, because it might not be as easy to find. And remember, if a pulse is under 60 beats per minute in an infant, you should still start CPR on them. And then you have your carotid, which is felt along the large carotid artery on either side of the patient's neck. When you're assessing the pulse, you are counting pulsations for 30 seconds and multiplying them by 2, and that is your pulse rate over a minute. If the rate, the rhythm, or force is not normal, then you're going to continue to count for the full 60 seconds. And then judge the rhythm and the force. Next is respirations. With regard to vital signs, respiration means the act of breathing in and out. It's the measurement that includes both the rate and the quality. Here is them assessing the respiration rate and quality by counting for 30 seconds and then again multiplying by 2. I highly recommend when you're doing the pulse to do the full 30 seconds because 15 and timesing it by 4 is just not adequate. So the respiration rate is the number of breaths the patient takes in 1 minute, and the rate of respiration is classified as normal, rapid, or slow. The normal rate for an adult at rest is between 12 and 20 breaths per minute. Age, sex, size, physical conditioning, and emotional state influence breathing rates. Unusually fast or slow respiratory rates may require oxygen administration or providing ventilations to the patient in respiratory failure. For respiratory quality, there's 4 categories: normal, shallow, labored, or noisy. With your respiratory rhythm, if you observe irregular respirations in an unconscious patient, you should report and document it. Count respirations after assessing a pulse rate. You want to count the number of breaths taken over 30 seconds and multiply it by 2. Note the rate, the quality, and the rhythm of the respiration. I highly recommend still feeling for a pulse when you're checking the respiration rate because the patient will feel like you're checking their pulse when really you're checking their respirations. Once in a great while, and not necessarily intentionally, they will either breathe faster or slower because they know that you're doing it. And it might not be intentional, but it can happen. For the skin, remember you're going to check the color, the temperature, and the condition of the skin, which can provide valuable information regarding circulation. For color, the best places to assess the skin color in adults are the nail beds, the inside of the cheek, the inside of the lower eyelids. In infants and children, the palms of the hand and the soles of the feet. And in patients with darker skin, their lips and nail beds. Abnormal skin colors are pale, cyanotic, which is the blue-gray color, flushed, which is the red, and jaundice, which is the yellow. Skin temperature, you want to feel the patient's skin for that with the back of your hand and note if the skin feels normal, warm, hot, cool, or cold. Here's what I'm talking about when I'm saying determining the skin temp by the back of your hand. So here's something to think about from the pediatric standpoint. For children under 6 years, also evaluate capillary refill. Press on the nail bed or the top of the hand or foot and release. Observe how long it takes normal pink color to return. Normal is less than 2 seconds. Pupils are the black center of that eye. The dim environment, the pupils will dilate or get bigger. In bright environments, the pupils will constrict or get smaller. When assessing, you want to look for the size, the equality, and the reactivity of the pupils. You want to note that baseline size and cover one eye and shine a light into the other eye, and then repeat it with the additional eye. Here's how you examine pupils. And you will take the light from the side of the face and you'll come in at the pupil, and then you'll lower it or shut it off and go to the other side of the pupil, and you will determine the reaction and the pupil size and etc. On the top picture is constricted pupils, so that's that pinpoint or smaller, and that's when you're going to see that they have bright light in front of them. That's what their eyes will look like. And then you have the dilated pupils, which are in the middle, and then you also have the unequal pupils that are at the bottom. Now, some people do have unequal pupils. However, if you do see this unequal pupils, you do have to think about head injury. Unequal pupils can be a sign of the influence of a topical drug. One placed directly on the eye, such as an eye drop, or if they happen to have a head or an eye injury. Next, we're going to talk about blood pressure. So that's the force of blood against the walls of the blood vessels. So the systolic pressure is created when the heart contracts and forces blood into the arteries. and diastolic pressure remaining in the arteries when the left ventricle relaxes and refills. A normal pressure is systolic no greater than 120 and diastolic no greater than 80. Change can indicate something very significant. So that's why, again, we always like those trending blood pressures. It is measured with a blood pressure cuff and stethoscope. The cuff should cover 2/3 of the upper arm, elbow to shoulder. Here's how you should position the blood pressure cuff. Measured with a blood pressure cuff and stethoscope, you want to wrap that cuff around the patient's upper arm. Place the lower edge of the cuff about 1 inch above the crease of the elbow, and place the center of the bladder over the brachial artery. Next, we'll talk about determining blood pressure by auscultation. So first, you want to prepare the patient. Position the cuff in the stethoscope. You want to palpate the brachial artery at the crease of the elbow. Position the stethoscope. Position the diaphragm of the stethoscope directly over the brachial pulse or the medial anterior elbow. When measuring blood pressure by auscultation, you want to locate the brachial artery by palpation before placing the stethoscope. You're going to inflate the cuff and then listen and inflate until the gauge reads 30 or higher, then the point that the pulse sound disappears. Then obtain that systolic pressure. You're going to slowly release the air from the cuff, and when you hear the first of these sounds, note the reading on the gauge, and that is your systolic blood pressure. To obtain a diastolic pressure, you want to continue to deflate the cuff, and when the sounds turn to a dull, muffled thuds, the reading on the gauge is a diastolic pressure. That's when you're going to record the measurements. Next, we're going to talk about determining blood pressure by palpation. So you're going to position the cuff and find that radial pulse. Once you get done with that, then you're going to inflate the cuff and then obtain and record the systolic blood pressure. So how you're going to do that is slowly deflate the cup, and you want to note reading when the radial pulse returns, which is then that systolic pressure. This is not the best blood pressure, but it is something if you don't have a stethoscope, or if you're in a loud area, or if you just can't hear it with the stethoscope and so forth, then you can try this. So pediatric note 1. It is difficult to obtain on infants and children younger than 3 years of age. More useful information about the condition of an infant or very young child comes from observing for conditions such as sick appearance, respiratory distress, or unconsciousness. Next, we're going to talk about determining blood pressure by blood pressure monitor. So you're going to position the cuff, inflate it, and then obtain and record the systolic pressure while you're slowly deflating that cuff. Next, we're going to talk about temperature. So there's a narrow range of temperature which allows chemical reactions and other activities to take place inside of the body. The core temperature reflects the level of heat that is inside the trunk or the body. Normal temperature depends on the time of the day, the activity level, their age, and where it was measured. So here you'll see an electronic thermostat, which is safer and more hygienic, and it's quicker to produce a reading than a glass thermometer. In this section, we're going to discuss monitoring devices. All right, first we're going to talk about oxygen saturation. It's also called SpO2. So the ratio of the amount of oxygen present in the blood to the amount that could be carried, expressed as a percentage. So measured with that pulse oximeter. Here is what a pulse oximeter with a sensor applied to the patient's finger looks like. And again, there's many different oxygen saturation devices. So again, going back to your respective service you'll be working for and figure out which one they specifically use. There are just little ones that go in the fingernail that have everything right on that finger piece rather than having this bigger machine. So when to use a pulse oximeter. So your protocol should govern when to use a pulse ox if your service has one. Generally, it includes all patients complaining of respiratory problems or otherwise at risk for hypoxia. I always tell everybody, get into the habit of doing a pulse ox on every single patient, because in the end, if you don't do it all the time, you're going to eventually forget it. And then on that important patient who you may not have put that pulse ox on, maybe their O2 stats are only at 82%, and really the only thing you have to do is give them oxygen. So I highly recommend, from my own personal opinion, is to put it on every single patient. However, make sure you check your protocols and make sure that that's okay to do as well. So interpreting a pulse oximeter reading. So normal reading is 96 to 100%. Mild hypoxia is 91 to 95%. Significant or moderate is 86 to 90%, and severe hypoxia is 85% or less. So remember that a reading above 96% does not mean that you should withhold oxygen from the patient with signs and symptoms that need it, but just know that anything over 94%, you really don't have to give oxygen if they're not complaining about it. But again, if they are complaining about it, I highly recommend just giving it to them. If nothing else, it'll make them feel better and hopefully calm them down. But I would only start out with that nasal cannula at that point. Your accuracy of readings can be affected by many different things. So shock and hypothermia can affect it. Carbon monoxide and certain other common types of poisoning can affect it. Excessive movement, nail polish, anemia, and hypovolemia are some things that can actually be affected by inaccurate reading. Next is blood glucose meters. So you want to measure the quantity of glucose in the bloodstream, and it can help identify some diabetic emergencies. So it can identify if you have high blood sugar or low blood sugar, and then that will help you determine if you need to give them sugar or if you need to get them to the hospital to get them IV fluids so they can start lowering their blood sugar. So here's a blood glucose meter that is out there. There's many EMS systems that do allow EMTs to use the blood glucose meters that are carried on ambulances. So again, going back to your service and knowing and understanding what your service carries and how to use it. When you're using a blood glucose meter, you do have to have permission from your medical director, or local protocol is required to perform a blood glucose monitoring using that glucometer meter. So monitors must be also calibrated and stored according to the manufacturer's recommendations, or they may not be covered under certain situations. Using a blood glucose meter. So first you're going to prepare the device, the test strip, and the lancet. You're going to cleanse the patient's fingers with alcohol, perform a finger stick with the lancet, apply the blood to the test strip, and then use the glucose meter to analyze a sample and provide you back with a reading. If you have a normal level, you're usually at least 70 to 100, and it depends on the manufacturer's instructions and the local protocols what you should do next. Next, we'll talk about capnography. This is measuring the amount of carbon dioxide that's exhaled. So it's the end-tidal carbon dioxide, or the EtCO2. Normal level is 35 to 45. And what does it do? It indirectly indicates how well tissues are using oxygen and performing other physiological functions. So some methods that can be used is where the patient is breathing spontaneous, has special nasal cannula applied that will actually measure that the EtCO2. Or in the ventilated patients, there is a plastic collar that fits between the bag valve and the mask or the advanced airway. So again, not all services carry it, but if they do, this is something to ask questions on and find out if you have it and how it's used. All right, let's do a quick chapter review. You gain a great deal of information about a patient's condition by taking a complete set of baseline vital signs, including the pulse, respirations, skin, pupils, and blood pressure. The EMT must become familiar with the normal ranges for pulse, respirations, and blood pressures in adults and children. Trends in patient's condition will become apparent only when vital signs are repeated, an important step in continuing assessment. How often you repeat vital signs will depend on the patient's condition. It's at least every 15 minutes for stable patients and at least every 5 minutes for unstable patients. You want to remember to consider if there is time to obtain vital signs or if you must wait to obtain them until you're en route to the hospital. You want to consider when to apply a pulse ox. Should you apply it to a patient with difficulty breathing or without difficulty breathing? You want to remember to consider whether abnormal vital signs are a result of an illness or an injury or the result of some other factor. Some questions to consider are name the vital signs. Okay, what are some vital signs that you know that you have to take? It should be the pulse, the respirations, the blood pressure, the skin quality, mental status, pulse ox, and pupils. Obtaining more than one set of vital signs allows you to identify those trends in either improvement or deterioration. So that is why it is, again, very important to obtain more than one set. And then how much time should be spent looking for a pulse when the radial pulse is absent or extremely weak? And so you shouldn't spend any more than 10 seconds looking for that pulse. If it takes you more than 10 seconds and you don't feel a pulse or you're not sure, you should immediately begin CPR. So how should you react when the blood pressure monitor gives a reading that is extremely different from previous readings? And then how can you get an accurate pulse ox reading on a patient with a thick artificial nail? So remember, blood pressure monitors are sometimes inaccurate. You should trust the trend and obtain a manual pressure to confirm this if you do have any issues with the manual one or with the electronic one. Sometimes a patient's heart will have an electrical problem and beat more than 200 times per minute. Why is the pulse so weak in such a patient? So just remember that faster heart rates can prevent filling of the heart. So with this drop in preload, cardiac output also suffers. So if little blood is being ejected from the heart, pressure will not be normal and the pulse will be weak. For any questions, please reach out to your instructor. Thank you and have a great day.